Good afternoon, everyone, those here and online. Thank you for joining the seminar today. My name is Chizitara, Nkwopara, and today I'll be presenting on the link between ergonomic risks, pain, and mental health in young construction workers. I'd like to acknowledge that this research was conducted across the traditional, ancestral, and unceded territories of different Coast Salish peoples, including the Squamish, Musqueam, Tsleil-Waututh, Coquitlam, Kwantlen, and Okanagan nations. I'd also like to acknowledge that this research was conducted under the leadership of the Partnership for Work Health and Safety, which is a research unit located here on the 3rd floor of the SPPH building. And there are a couple of us here today in the room. Thank you for joining. Okay, so we'll begin with our first poll question. I'd like to get us engaged. And the first question is, between 2019 and 2023, how did the serious injury rates in BC's construction industry compare to the provincial average across all industries? And there are 4 options with one answer, just one option correct. Okay, I can see responses trickling in. Okay, I can see how many responses, about, okay, 65% participants. And I see that most people have responded that the construction industry had more than double the injury rate compared to the provincial average, and that is correct. I will show a bit more about that in our next slide. Okay, so this stats are from WorkSafe BC. The serious injury rate in the construction industry in BC was about 0.68 compared to the serious injury rate for all other sectors in BC, which is 0.9. So you can see that that's well over double the injury rate. And most of the claims in that time period were from, or 30% of the claims were musculoskeletal injuries during that time frame. So a bit more about background of this study. Many studies have shown that compared to other workers, construction workers face significantly higher exposure to ergonomic risk factors, such as overexertion, repetitive motion, and upward postures. And musculoskeletal pain, particularly in the lower back, the shoulders and lower extremities, have been linked to ergonomic risks. Also, research has shown that young construction workers are particularly vulnerable to these injuries and risks early on in their careers. The implications of ergonomic risk factors and pain on the physical health of construction workers is well established in the literature. However, their impact on the mental health of construction workers is still underexplored. Therefore, this pilot study plays an important role in filling an important research gap by exploring the relationship between ergonomic risk factors, pain, and mental health in young construction workers, particularly because there is limited and growing research or studies on young workers and mental health in BC and across Canada generally. And this project is also dear to me, as Chris mentioned, because I've worked in construction as a safety officer, and I was also a young worker when I started out. We have another poll question, because before we get into the findings, I want to get a sense of what people think affects the mental health of young construction workers. See people, responses coming in. Okay, almost at 65, okay, 62% of participants have responded. So thank you all for responding. The short answer is they're all correct. All these factors play different roles in affecting the mental health of young construction workers, and we'll see how that happens along the presentation. Okay, so for this study, our first research question was to look at the prevalence of ergonomic risk factors, pain, and poor mental health in young construction workers. And then the next question was to look at how pain is associated with the main relationship between ergonomic risk factors and mental health. We also wanted to look at how other factors like social demographic, occupational, and workplace relationships affect that main relationship between ergonomic risk factors and mental health. So from my literature review, I developed this conceptual framework which guided the study hypothesis. It also guided the survey that I developed for this study, as well as the analysis. And the main aim of this study was to look at the relationship between ergonomic risk factors and poor mental health outcomes. But we also wanted to see how musculoskeletal pain is associated or plays a role in that relationship, as shown by the solid arrows. And then for the secondary hypothesis, we wanted to understand how other factors, social demographic, occupational variables, and workplace relationship play a role in that main relationship, as shown by the dotted arrows. This study was carried out using a cross-sectional survey informed by existing research and validated questionnaires. And the survey was developed and administered using an online tool called Qualtrics. Now, this table summarizes the variables we looked at. The outcome variable is mental health. The primary independent variable is ergonomic risk factors. Secondary independent variable was musculoskeletal pain. We looked at other factors like functional health and well-being, psychosocial risk factors, help-seeking behaviors. But for this presentation, I'm going to be talking about social demographic, occupational, and workplace relationships and how they affect the independent and outcome variables. This was the flyer we used for recruitment. Harman is here in the room. Harman helped me. We went to about 140 construction sites across the Lower Mainland and Okanagan regions. And then in order to get the survey to other areas of BC, we partnered with over 112 organizations, including construction companies, unions, trade schools, mental health and youth-focused organizations as well. And then there's a picture of me, one of the mornings, getting ready to head to site. I was probably on my way to meet up with Harman, and then we're going to drive to the site. Okay, so now let's go into the questions which were asked in the survey for the key study variables. The first one is mental health. So what I did was to ask the participants to rate their overall mental health in the past 4 weeks. And this included 5 categories: poor, fair, good, very good, and excellent. And for analysis, what I did was to collapse these into 3 categories. So I combined poor and fair. I left good because they were, like, most of the respondents fell into good, and then very good and excellent were combined. And then for ergonomic risk factors, we looked at 4 of them. We looked at high repetition, static posture, awkward postures, forceful exertions. Also 5 categories which were collapsed into 3: never and rarely, sometimes on its own, often and always, just to show the frequency of exposure. And then what we did was to sum up all the ergonomic risk factors to get an overall score of 12. And then to understand the risk distribution amongst the participants, I separated the overall risk score into 4 different categories. So low risk was from 0 to 3, moderate risk was 4 to 5, moderate high risk was 6 to 7, and then high risk was 8 to 12. And then for pain, we used the Nordic musculoskeletal survey. So this is just an image from it. We asked them, a yes or no question or answer to experiencing pain in 9 different body parts, as you can see. And then what I did was to group these 9 different body parts into 4 body regions: upper extremity, upper back, and lower extremity. So at the end of our recruitment, we got 1,446 attempts at our survey. And then to ensure the integrity of the results, we applied a couple of these security and exclusion criteria. The first one is the reCAPTCHA score, which is a security scanner on Google, so which prevents bots from filling out the survey. We also use the Qualtrics fraud score so we cut off, or we didn't include responses with a fraud score of 30 or above. So that told us that was probably fraudulent or a bot filling out the survey. Age mismatch. So we snuck in 2 age questions at the beginning of the survey and at the end. And if their response to the age didn't match, we took those out because you should be able to know your age. We took our responses from outside of BC because this study was focused on BC. We also took out responses that the completion time was less than 6 minutes because we did an average of how long it takes to complete the survey. So that told us, something was going on there. Now for the analysis, we used chi-square tests to show the differences in mental health proportions in the study variables. And then we used odds ratios and 95% confidence intervals in adjusted logistic regression models to determine the strength of association between the study variables. Now for this study, 2 fully adjusted models were used, one with ergonomic risk factors alone as the independent variable, and then the second one with pain. That's the only difference between the two models. The 2 models were built stepwise, first of all, by including the independent variable or variables, and then we gradually or sequentially included socio-demographic variables, occupational variables, and workplace relationship variables. And then the model fit was determined by the reduction in the AIC, or the Archaic Information Criteria, and all analysis was done using Stata. Okay, so now we are at the results. Before I go in, the first result we're going to look at is the overall distribution of the mental health among the 366 participants. So the blue bar determines or depicts poor or fair mental health. Like I said, I collapsed them into 3 categories. The bright green shows good and dark green shows excellent. So here we can see that out of the 366 participants, about 37% of them reported poor or fair mental health, and about 39% of them reported good, while about 24% of them reported excellent mental health in the past 4 weeks. Next result shows the prevalence of ergonomic risk factors and pain according to the mental health categories. Now for ergonomic risk factors, we can see an almost downward trend if you take a look at the blue bars in reporting mental health, and we can see it goes from high risk to low risk, showing that those who are exposed to the highest ergonomic risk are more likely to report poor mental health. We have about 65% of them reporting poor mental health in that category. And then for musculoskeletal pain, we can see that those who reported not experiencing any kind of pain were the least people to fall into the poor mental health category. And then we can see the highest concentration of people reporting poor mental health in the lower back pain category, of those who experience lower back pain, followed closely by those who experience lower extremity pain. This also shows the distribution and prevalence of supervisory and co-worker relationships, also by mental health categories. And for both of them, we can see also similar trends where those who have or those who report poor supervisory and poor co-working relationships also have the highest proportion of poor mental health. Here we have gender and age and ethnicity. For gender, we can see that women or female workers only made up about 10% of the study population, just 35 of them, but we can see that they have a very high proportion of poor mental health, over 50% of them reporting that. And then for age, we have kind of like a bimodal distribution on the 2 extremes of the age. So we have younger workers reporting very high proportions of poor mental health. We also have older workers doing the same thing. For ethnicity, we have disproportionately higher poor mental health reporting among the Latino, Latina, and Latinx workers, followed closely by Black workers and then Indigenous workers. And then finally, this is distribution of mental health status according to trade training or construction training, work experience, and the trades. For training, we can see that compared to those who have completed training or enrolled training, those who reported to have no form of construction training reported the highest proportion of poor mental health. And then for work experience, we kind of see a downward trend as well. So those who have stayed longer in the construction industry reported poorer mental health outcomes. And then for the trades, it's kind of, there's really no trend per se, but I can see that for some of the specialized trades is where we have the highest proportion of poor mental health. For instance, installers, electrical trades, plumbers, and carpenters show high proportions of poor mental health. So the next thing we're looking at now is the odds ratios. This is the odds ratios for ergonomic risk factors in the fully adjusted models. And I'd like to remind you or reiterate that the first model is the one with ergonomic risk factors alone as the primary independent variable. And the second one includes ergonomic risk factors and pain. And before I go into this, I'd just like to give a short explanation. Explaining what odds ratios are. So odds ratios are used to quantify the likelihood of an outcome happening, and the outcome in this study is poor mental health, given an exposure. So the exposure here is ergonomic risk factors, and then when you have the baseline kind of shows 1. So when an odds ratio is higher than 1, it indicates stronger negative association, meaning that when people or workers are exposed to the exposure, which is ergonomic risk, they are more likely to report poorer mental health. When the odds ratio is 1, it means a weak association or a weak relationship between the two variables. When the odds ratio is lower than 1, it means a positive association, meaning that the exposure acts as kind of like a protective factor, or there is a positive association between the two variables. So for this result, we can see that there's a strong negative association between ergonomic risk factors and poor mental health outcomes. And between the two models, the odds ratios range from 2 to about 10 compared to those in the low risk category or low ergonomic risk category. We also see that in the second model, when pain was added, we can see a reduction in the odds ratio of the ergonomic risk factors. For instance, high risk dropped from 9.69 to 5.25. Moderate risk dropped from 3.54 to 3.08. So that tells us that something happened when pain was included in the model, and pain might explain something in the pathway between ergonomic risk factors and mental health outcomes. Here we're looking at the odds ratios of musculoskeletal pain, and we can also see a negative association, a strong negative association between musculoskeletal pain and mental health outcomes. And we see that compared to those workers with no pain, workers who experience any kind of pain are up to 3 times more likely to experience poor mental health outcomes. And we see that strongly in lower extremity pain and lower back pain, which kind of tallies with what we saw in the bar charts. Finally, I just put a summary of different explanatory variables. So other variables in the model that had like a strong association with mental health outcomes. And here I'll point out training. We see that those workers with no training at all have up to 11 times the odds of reporting poor mental health outcomes. Same for years of experience, 5 years. Those with 5 or more years of experience have up to 3 times or even more the odds of reporting poor mental health outcomes. And then we see an opposite trend when it comes to relationships, so supervisory relationships and co-working relationships. We see that the odds ratios fall below 1. And so those who have good or positive relationships with their supervisors and co-workers are less likely to report poor mental health outcomes. Okay. So summary of the key takeaways from the results. We saw a high prevalence of poor mental health outcomes. We also saw a high prevalence of ergonomic risks, and as well as pain in the lower back and lower extremity. So we saw significant relationships between ergonomic risks and mental health outcomes. Same for pain, musculoskeletal pain. We also see that pain potentially mediates the relationship between ergonomic risk factors and mental health outcomes. And we saw that when pain was added into the second adjusted model, and we saw a reduction in the odds ratio of ergonomic risk factors. For formal training and social support or workplace relationships, we noticed that those could be potentially protective factors because those workers who did not receive any kind of training had up to 11 times the odds of reporting poor mental health, and the reverse was for social support or positive workplace relationships where they were less likely to report poor mental health outcomes. Okay, so this is our final poll question, and so with what you know now, with the results that were shared, what are some factors that you think you can improve at your workplace, or if there's one thing that you can do or change at your workplace to improve workers' mental and physical well-being, what would it be? Thank you for the responses. They're trickling in. Just waiting to get to up to about 60% or 62% responses. Okay, yeah. So I see most people saying supervisory leadership training or supervisor leadership or training. I would actually go with that. I feel like that will be one of the less cost effective things to do, something that can be organized fairly quickly and that could have a huge impact because these workers, people who filled out the surveys are telling us that something is very important. Having positive relationships with their supervisor or even co-workers goes a long way when it comes to their mental health. Okay, so now let's talk about the strengths and limitations of the study. Let's make sure I get rid of this poll. Okay, so the main strength of the study is that it demonstrates strong face validity. So we saw similar trends across the data. What we saw, or the trends we saw in the bar charts or in the chi-square test were similar to what we saw in fully adjusted models. Another thing that we did right was how we designed the incentive structure for the study. So rather than giving each individual participant some sort of compensation, we did a random draw, and that helped us to minimize the risk of fraudulent responses. Then the main weakness or limitation of this study is that it might be subject to healthy worker bias, and this can go both ways. So the first one is we might have lost some workers early on, due to having musculoskeletal pain, chronic pain, or injury. So they might have left the trade too early before we capture, their stats. And it can also go the other way where people who are more prone or who have experienced poorer physical or mental health challenges in the construction industry might have been more motivated to fill out the survey. So that might have led to an overestimation of those outcomes. And finally, we cannot establish causality or directionality between the two variables because this was a cross-sectional study that captures information or data at a point in time. So based on the findings of the study, there are a couple of things to think about. And first, I believe that existing ergonomic interventions and training can benefit from integrating mental health literacy. And I believe that young workers, especially those in apprentice schools, trade training, younger workers should be trained on the risk or the link between ergonomic risk exposure and mental health outcomes. I also believe that to enhance existing pain prevention measures, workplace-based recovery clinics or e-health tools can be introduced. And these clinics could provide voluntary pain screening, pain management training, as well as mental health counseling. And the idea is to make the access to healthcare professionals more accessible to those in remote sites or, in just general construction sites in general, unlike traditional healthcare where they actually have to go to the hospital to get care. Also, given the positive association between good supervisory relationship and better mental health outcomes, I believe that supervisors should be trained in like mental health first aid. They should be given good training on how to maintain positive leadership with workers, and not only should they be trained, but they should be assessed on how they are using the training to make mental health conversations more of a thing at the work site, during toolbox talks, during their meetings. And finally, in prioritizing psychological safety alongside ergonomic safety and pain management, we can also consider including mental health well-being metrics into inspections and workplace safety evaluations. Future research, because this study was a pilot study, was preliminary research. There are a couple of things we can think, I can suggest that can be done in future. First is obviously to do a longitudinal study. So this can help to determine directionality or causality between the variables. Also, even though we saw attenuation of the odds ratios when we added pain into the second logistic model, we also advised that a formal mediation analysis be done to actually disprove or confirm the role of pain as a mediator in this study. And then to address the underestimation or overestimation of study measures, we can link the findings from the survey to external data, such as claims data or injury data, just to know whether we are overestimating or underestimating the findings of the study. And finally, the survey should be translated into other languages, because one of the things I noticed in some of the websites is they couldn't fill out the survey because it was in English language. And so that's definitely a barrier to collecting data. And also, we'll also suggest that, apart from the variables we looked at, we look at how some other variables or factors affect that relationship between ergonomic risk factors, pain and mental health, such as bullying, harassment, and discrimination, substance use, and health-seeking behaviors. So for substance use, I highlighted this because we're currently doing some further analysis to look at how that plays a role in the key relationship. And finally, we've come to the end of the study. I'd like to acknowledge that this study was funded through a WorkSafe BC research grant. All inferences, opinions, and conclusions drawn in the presentation are those of me or the authors and do not reflect the views of the funder. I would also like to thank my wonderful research committee, made up of Dr. Chris McLeod, Dr. Melanie Gorman, and Dr. Martin Gunn. Thank you for your guidance and support throughout this research from the beginning to the end. I'm also grateful to the team at the Partnership for Work Health and Safety for all your support, your expertise, and also the research assistant opportunity, which I got when I came here. I definitely learned a lot. And finally, I would like to acknowledge and thank WorkSafe BC for generously funding this study. Without the funding, it wouldn't have been possible. Thank you. So, questions?
Thank you very much. I think we've got a few questions in the group. Some students, whether you want to come up to the microphone here, it may be easier for the audience online.
Want to know why you set the target to the young worker from a very broad age, from the